Hi everyone, my name's Keisha Katula. I'm a graduate student in the Nurse Educator program here at NDSU. I'm also a clinical instructor for critical care clinical, and then also I'm an RN who works in cardiac ICU. And so today, as part of my practicum, I'm going to be recording 3 different videos on cardiac rhythm analysis. And so far, you have learned about the different rhythms and the different components of the cardiac cycle through lecture. And now today I'm going to be talking about my method of how I interpret cardiac rhythms. And so this isn't meant to be, 100% comprehensive on every rhythm that you'll encounter, but it is a good way to start thinking about a method to analyze the rhythms. The goal is for you to have a process in place. Instead of depending on just pure recognition of the rhythms, having a method and steps that you can follow so that you can have the tools in place so that you can analyze any rhythm that's put in front of you. So I listed a couple of the steps up here, and these are the ones that I'm going to be referring back to as we're going through the different rhythms. And so I'm going to leave those up. How I start out with any rhythm analysis is I first start out with looking at, is the rhythm regular or irregular? So a good way to do this, and you can do this with any EKG paper that you have. So if you have your cardiac rhythm, and here are your P wave and your QRS, P wave, QRS. A good method just to do a quick check on regularity would be to take a piece of paper and line it up with your R waves, so with each QRS, and make a little dash on each R wave, so you have a couple little marks. And then with that, you can move it over to check regularity. So due to my maybe less than stellar drawing skills, this one was intended to be regular, but it's not. It comes a little bit early. So that is one method, just to do a quick check of regularity or irregularity. So that's the first step. Next, we look at, are there P waves? Yes or no? So we're looking at the rhythm. Yes, we have P waves. And then, is there one for every QRS? Yes, there is. If not, you're going to start thinking, okay, there's some kind of arrhythmia going on, and it's going to alert you to kind of further investigate it. So we have P waves for every QRS, and next would be to measure the PR interval. So that is from the beginning of the P wave to right before the QRS here. The Q is actually a slight downward deflection before your R wave. So you're going to about here of the QRS. That PR interval we want to be less than 0.2 seconds. And that PR interval is going to be important when we start talking about the different AV blocks as we go on. And then we're going to measure the QRS, which is from that Q wave, that slight downward deflection, to our S right here. And that we want to be less than 0.12. And so now that's the method that I use. That's my method of analysis. Of course, there's other components as well, but that will get you on your way to analyzing the rhythm itself. So now I'm going to go on to, for the rest of this video, I'm going to talk about the different sinus rhythms. So normal sinus rhythm, sinus bradycardia, and sinus tachycardia. And we'll talk about, just briefly, about common treatments for those. So this one's pretty close to normal sinus rhythm. We'll leave it at that. First check would be, and maybe we can label it here, normal sinus rhythm. So normal sinus rhythm is what we want, right? That's the heart rate is going to be 60 to 100 beats per minute, because our impulse is being originated in the SA node, right where we want it to. And that impulse is going down the correct conduction pathway and the ventricles are contracting like they should, and we have a nice, beautiful rhythm. So another thing that we can start to reference is we'll have this circle depicting the heart. So this is we'll call these your atria up here, and your ventricles down here. Your SA node resides way up there in the atria. So that's your pacemaker of the heart. And that normal rate is going to be 60 to 100. So with normal sinus rhythm, that's where this electrical impulse is going to start. So the SA node fires, it says, all right, atria, contract. It sends the impulse down, and providing we have mechanical capture, we get a nice P wave. That is atrial, so the P wave is atrial depolarization or contraction. Your P wave, right up there. As this impulse comes down, it's gonna go through, it'll go through the septum here, down the septum, out down the bundle of His, which is along the septum between the two ventricles, out through the Purkinje fibers, and that impulse tells the ventricles to contract. And so providing we have a normal pathway, which we do with normal sinus rhythm, we have a nice narrow QRS that shows ventricular depolarization or contraction. So your QRS is what's showing the ventricles contracting. So it's helpful to think of this that it's all in time, that your EKG tracing is really the electrical conduction, and it's shown over a course of time. So with normal sinus rhythm, everything is in its normal time frame. The P wave looks normal. The PR interval is going to be less than 0.12, and that's because the time that it takes for that signal to go from the atria contracting here down through the AV node and for the ventricles to contract, that impulse time is normal. It's less than 0.12. And so it helps to think of that if there's going to be a block, which we'll talk about in a little bit, then that time is going to be prolonged. It's taking longer for that impulse to travel that distance in the heart. So hopefully it helps to make sense that with the physical nature of the heart and then how the conduction pathway is going. So that's normal sinus rhythm. As we go on to, so there's nothing wrong with that one. Your normal rate is 60 to 100, and that one's beautiful. If everything else is good, you're regular, you have P waves for every QRS, your PR interval looks good, QRS looks good, and it's just slow. So it might look something like there's just longer in between. Let's say your rate is less than 60, but everything else being normal. That's going to be sinus bradycardia. Sinus bradycardia. With this, your impulse is still coming from that SA node. It's just that SA node is firing slower than it should be. It's firing less than 60 beats per minute. But that conduction is still going to be normal, evidenced by everything else being normal. So treatment for sinus bradycardia really starts with assessing your patient. Sinus brady can be something that's normal for really well-trained athletes or people with very conditioned hearts. But it can be that patients are very symptomatic with it as well. So as with every rhythm, we're assessing the patient along with the monitor, the patient along with the rhythm. So what is their tolerance of it? We may be asking them if they feel dizzy, lightheaded, syncopal. If they've had syncopal episodes, we'll be assessing their blood pressure and things like that. If they are asymptomatic with their sinus bradycardia, then we just monitor. There's no treatment. If they are symptomatic, we can do a couple of things. Atropine is a drug that we can give. And if they're symptomatic and it's chronic, then they may need a pacemaker. So that is sinus bradycardia. All right, on to our next one. Everything else being normal, it's nice and regular. We have P waves. We have a P wave for every QRS. Our PR interval here is less than 0.12, or I'm sorry, less than 0.2. QRS is nice and narrow and of normal shape. It's just fast. This is a faster than 100 beats per minute rate. And so what we would call this is sinus tachycardia. So still, the impulse is coming up from the SA node, just like we want it to, traveling down the right conduction pathway. There's no blockages. It's just firing fast. This can be due to a variety of stimulants, caffeine, some medications can cause it as well, stress, pain. And for treatment for this, we look at, first, patient's tolerance, of course, but two, trying to identify the cause of it. So are they having are they in sinus tachycardia because they're in pain? Then maybe we need to control their pain, and that might handle the sinus tachycardia. A medication that we can give is a beta blocker too. That would also lower the heart rate. So those are the sinus rhythms. Okay, so on to our next. Now we're getting into more of the dysrhythmias. So you're going through your steps and you're noticing that it's regular. It's a nice regular rhythm. The QRSs march out, we'll say. We have P waves. We have a P wave for every QRS. But okay, so we're going to start to measure that PR interval. And what looks wrong with it? It's long, right? This is longer than 0.2 seconds. So this PR is greater than 0.2 seconds. So this is what we call a first degree AV block. So back to our beautiful picture of the heart here. We have the impulse originating from the SA node, just like it should. We have the atrial depolarization, the atrial contraction, depicted by the P wave. But as it comes down and it kind of travels past this AV node that's along the septum, there's a blockage. And so the block that's maybe right here is slowing down the impulse. The impulse that's coming from up in the SA node, atria are depolarizing, and then that impulse should come down and tell the ventricles to depolarize, and so we get a QRS. There's a block there prolonging it. So an AV block, kind of by the AV node. There's a block, but after it gets past the block, comes down, and then we have normal conduction after that. So we have a normal QRS. So a first degree AV block is a prolonged PR interval that is consistent. So this PR, let's say it's 0.24. Let's give it that number. As you would go on, this PR would be 0.24. And then this one would be 0.24. So it's consistently prolonged PR interval. That is the first degree AV block. So whenever you have issues with your PR interval as you're going down your list here, you're gonna think AV block. So PR, AV block. That's the first degree. All right. So all right. So this next one is another degree of AV block. So, as you're going through, looks pretty regular. We have P waves. We have a P wave for every QRS that we have. Our PR. So we start out, and this isn't on EKG paper, so I'll provide it for you. Let's say this PR is 0.18. Okay, that's good, right? It's less than 0.2. As you go on, it's 0.22. This one is 0.25. And what happens to this one? It's a dropped beat. Finally, there's no QRS. So this is second degree type 1 or Winky Bach. Second degree type 1, oh, I should also include AV block. Second degree type 1 AV block is also called Winky Bach. And so a fun way to remember this, and I still say this to myself every time I do this kind of rhythm analysis at work in cardiac ICU, is longer, longer, longer drop, now you have a Winky Bach. So longer, longer, longer drop, now you have a Winky Bach. The key with this one is progressively longer PR intervals, which lead to a dropped QRS. So again, this is an issue with our PR, so there's a blockage along that pathway, all right? And the issue with this is that blockage gets more so and more so and more so until we finally, that impulse doesn't go through. It's a complete complete blockage for this beat, and we don't get a QRS. There's no ventricular depolarization. And then we just start over again. So it'll start over with the 0.18, 0.22, 0.25. And it's pretty rhythmic that way. That's longer, 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 and then finally a dropped beat. So that is the second degree type 1. With this one, we really just monitor. We assess their tolerance. We watch what their ventricular rate is, and that, if they're tolerating it, we really watch. It can be a warning sign that it can progress to something more serious, like a second degree type 2 or a third degree AV block. So we do watch that. Okay, this next one, I'm not actually going to draw out because it would get really confusing. The next one that we'll talk about is second degree type 2 AV block. So with this, what you want to think is too many P waves is a way to think of it. So with second degree type 2, it's intermittent dropping of the QRS. And so if it were depicted, you would see a bunch of random P waves. So as you're going through, you have P waves, and you have them for every QRS, but you have a whole lot of extra P waves. And so it seems as though that atrial rate is really irregular, or that it seems chaotic in that, because it's not nice, and with every QRS, a nice paired P wave. There's random intermittent dropping of QRSs. So again, it's an AV block. It's issue with the PR interval. And with this one, it can be a warning sign that they're going to progress into the next, which is a third degree AV block. And so with a second degree type 2, they may need a pacemaker at this point, but they do need definitely some monitoring to monitor for them to progress into a third degree. And that's our next one, which is also kind of hard to draw in that your P waves I'm trying to make it look a little bit more haphazard than it is. The main point with a third degree AV block is that the P waves march out, but there's no correlation with the QRSs. So maybe the drawing isn't a great depiction of that. Sometimes people will call it, I've heard cardiologists call the third degree AV block a divorce rhythm, in that there's no communication going on here between the atria and the ventricle. The SA node is firing just like it wants to, and it might be firing pretty regularly. There's no communication with the ventricle, so the ventricle is left to its own devices, and it just beats how it wants to. And what results is this third degree AV block, and the problem is that it's slow. And why it's slow is because, remember we said our rate we want 60 to 100 up in the SA node. That's normal. As we go down from the junctional node, your normal rate may be 40 to 60. As you get down into the ventricle, the normal rate is 20 to 40 beats per minute. And so with a third degree AV block, it's slow. It's left to beat at what the ventricle's intrinsic rate is, which is 20 to 40. And so treatment with this third degree AV block is a pacemaker. These patients need a pacemaker. And it's assessing how they're tolerating it as well. Of course, you're looking at your patient, but typically the heart rate is low. It's usually in the 30s when we see it. Some patients just complain that they've been tired or short of breath or less activity tolerance, and that's what prompts them to come in for care. Other times it's acute and they have a syncopal episode and they're very hypotensive, and we hook them up to the monitor and we find that they're actually in a third degree AV block, and their heart rate's 30 and their blood pressure's 70 over 30, and that's why they're feeling very very crummy. So third degree AV block, we need to get them a pacemaker, and sometimes we even need to give some atropine to get their heart rate up. So in this video, this is the first of 3, and I've talked about a little bit about the method of the rhythm analysis, sinus rhythm, sinus bradycardia, sinus tachycardia, and then the 4 different levels of the AV blocks. And so in the next video, I'm going to start talking about junctional rhythm and then the atrial dysrhythmias. But that's it for now.